In the October 28th issue of JACC, we're going to be taking a look at the clinical implications of a study that identifies 4 distinct phenotypes of chronic heart failure. And along those lines, I'm with G. Michael Felker, MD, who is a professor of medicine at Duke Clinical Research Institute. And you start out this paper noting that the contemporary classification of heart failure leaves a little something to be desired. Let's start there.
Yeah, so I think that's definitely true. First of all, I want to really recognize Tariq Ahmad, who was one of our cardiology fellows who really led this effort. And I think, if we think about how we classify heart failure patients, we use things like ejection fraction, New York Heart Association class, the ACC stages of A, B, C, and D. And those have all been useful, but they don't necessarily reflect biology. And in general, in diseases, we think sort of better classification and better taxonomy, if you will, can really help us assign the right treatments to the right patients. So what we did in this study, which was I think quite interesting, is basically tried to step back and say, let's say we really didn't know very much about heart failure. And we took data from a large clinical trial, the HF Action study, which is a randomized NIH trial of exercise training and chronic heart failure. And we took the main variables that describe the patients in the data set, which were baseline characteristics and medical history and laboratory data, echo and exercise testing. And we basically put them in a computer algorithm that said create some logical groups based on these groupings of information without a bunch of preconceived notions that maybe ischemic patients should be in one group and non-ischemic patients should be another. And then we looked at the clusters, as we call them, of patients that were described. And what was quite interesting is they actually really reflected the kind of patients we see in clinical practice. You could look at those groups of patients and say, oh yeah, like I know I have patients just like that.
That's my 2 o'clock right there.
Exactly. And just as a couple of examples, so there was one cluster of patients which was primarily younger, or a high rate of African American patients, and they had relatively low mortality, but very high hospitalization rate. And low quality of life scores, even though their more objective measures of heart failure like ejection fraction and BNP were not as severe. Another group, older white men mostly, with a huge amount of coronary disease and ischemic heart disease, very poor mortality outcomes, but good quality of life and very little angina. So I think we saw these kind of interesting, it wasn't just that all the sick patients were in one group and all the not so sick patients were in another. And then with all the limitations that this sort of connotates, we did an interesting thing, which was to actually look at within these different groups, what was the treatment effect of what we were doing in the trial, which was exercise training. And again, it's all post hoc, and I think you'd classify this as hypothesis generating. But we did see some interesting differences in the treatment effect of exercise in the different groups. And I think the implications of this is the kind of thing that's going to have to be validated, and this was obviously just one data set, and we're looking at validating it or evaluating in other data sets. I think you can imagine, though, that if you can come up with subgroups of heart failure patients that are more biologically similar, that you might increase your chances of identifying treatments that are going to be effective and given. So it's really about trying to understand this big, broad umbrella of what we call heart failure. What are really the biologic subtypes that make sense, and maybe we can in the future target those with specific interventions.
Could this explain some of the strange trial results that we've seen where a really good idea just seems to go astray, and it could be that we're just not grabbing the right patients?
Sure. So, I mean, if you think, and we didn't have any HFpEF or heart failure patients with preserved ejection fraction in our study, but HFpEF is really just a hodgepodge of a bunch of different diagnoses all sort of tossed into one bucket. And it might not be surprising, given that we've really struggled to identify effective treatments in those patients. And if you could take that big, broad group of patients and actually identify groups of patients whose fundamental biology was similar, the hope would be then that you could apply specific treatments to those groups and have a better chance of showing success.
And there's obvious clinical trial implications here.
I think so. I mean, we're at the very early stages, as I said, but I don't want to oversell the implications, but I think it is. It's one way of sort of using our what comes out of big data. A lot of this technology really derived in sort of the genomics area, where you have huge amounts of data and you're trying to identify patterns and clusters. Taking those sort of techniques and trying to apply them to sort of more routine clinical information, which I think is one of the really interesting things that Tarek did in the study.
I mean, there would have to be other areas in medicine where this could be an applicable approach.
Yeah, and it's been done in a few other things, chronic lung disease, but really, as we search the literature, we don't see very much of this, which is one reason I think it's sort of exciting. And maybe as this paper comes out, more people are going to get interested in this idea, and we may see more people using this technique in different data sets with hopefully some interesting results with good clinical implications down the road.
I mean, it's a great paper, and if you haven't seen it, it's in the October 28th issue of JACC. And for CardioSource World News, I'm Executive Editor Rick McGuire.